get very good gene expression. So these are all critical studies as we move forward. And again, we can thank Jesse's Journey for allowing us to have this kind of information. So one, we can deliver the gene successfully through the circulation. We can deal with pre-existing immunity, and this sets the stage for a vascular delivery clinical trial. Now, having said that, we're also trying to be a little bit more aggressive about limb perfusion, and we've actually, in the monkey now, started doing studies where I have an arrow that shows there where we can inject put the catheter in at a higher level and even get more muscles expressing the gene. So this again is a promising way of restoring the gene to the muscles of the leg. Now, I want to step back, and we started the first clinical trial that we ever did in Duchenne dystrophy. We started in 2006, and I think I probably talked about this when I was on site at one of your board meetings. We didn't have all the data, and it's taken us quite a bit of time to sort all this out. But we have a paper that's coming out in the New England Journal, and of course you know that is a very prestigious journal where we have to meet very high standards. And this is a very important paper because it really sets the stage of how we move forward. Now, what we found in the clinical trial, in the Duchenne dystrophy clinical trial that we're publishing in the New England Journal, is that we found obstacles to treatment that we didn't have any notion were there. And we found, we always thought that kids who were, even though they didn't have dystrophin, they had something called revertant fibers, and they would, and they always had a certain amount of underlying expression of dystrophin. But we found out that that didn't always protect them, and there are ways that there are other problems when we put in the gene. One is shown graphically on this slide, and this is probably very foreign to you when you look at it, but on the top picture of this cartoon is a child's gene with muscular dystrophy. And as you know, the most common mutation that causes muscular dystrophy are deletions of the gene. And this patient had a deletion of exon 3 to 17, which is a sizable deletion. And when we put in the mini-dystrophin gene, the gene of replacement, it expressed right in the area of the patient's gene deletion. When we did that, we found out that that caused an immune response. And we probably should have anticipated this, but no one in the field has ever done anything like this. And we really didn't predict that this would be the outcome. But this patient, when we expressed in that region, that spike there in this graph shows that there's an immune response to the gene that we put in, and that's really the sum and substance of that, which tells us as we move forward that we don't want to do that again, and that's part of what I'm going to be asking Jesse's Journey to help us with our next clinical project. But the other problem that we found out is that certain patients have pre-existing immunity to what we call revertant fibers. And this was really a totally new concept in the field. Now, revertant fibers probably don't mean a lot to most of you in the room. I don't know who all is in the room, actually, but some may know and most probably don't. But revertant fibers are, when you look at a muscular dystrophy biopsy, you see little clusters of muscle fibers that stain positively. And in this picture I have shown, if you look on the upper right-hand corner, even though this patient has a mutation at exon 50, they will express some dystrophin, and this we can see in this particular patient. But we have a way of actually profiling where the how this patient exactly is expressing these fibers. And we know that the deletion is in exon 50, but we know that he has to have a second site mutation somewhere muscle fibers and determine exactly where the second site mutation is. And this is basically exon skipping, just as we're going to do in a therapeutic trial. The whole concept of exon skipping came from understanding how revertant fibers express. But in some cases, these new epitopes, as we call them, that never showed any gene expression before, will have an immune response at that particular site. And again, I just show this to emphasize the point, but there's a big spike there, and that spike means that at exon 57, the patient began expressing this new form of dystrophin that he had never seen before and had an immune response. So these are two very important things that we learned from the clinical trial, and the reason that the New England Journal is very interested in publishing this, because this will help the whole field. As we move forward with a clinical trial, we learn two things. One, not to express the gene in an area of deletion, and to check the patients before we start the gene therapy as to whether they have revertant fibers. In fact, we are starting a new study right now where we'll be looking at 100 patients with Duchenne dystrophy to determine how many of a sample size of 100 have immunity to revertant fiber clusters. And I wanted to also mention that there are a number of other ongoing studies that we're going to be doing, and some of these would be of interest to you. One is we're looking we're doing a cardiomyopathy study. Over the past, about 2 years ago, there was a major publication that losartan was a drug that could help the heart function and also improve cardiac muscle. And there are other medications called ACE inhibitors that are used frequently in muscular dystrophy, and we're actually comparing the efficacy of losartan versus lisinopril. And again, that will be a very important study as we move forward, and we've enrolled now somewhere about 70 patients in this clinical trial. The next very exciting thing we're doing is we'll be the first North American site to do an exon skipping trial. This will start in about December. We're going to be enrolling 20 boys with muscular dystrophy into an exon skipping trial, and this will be skipping exon 51. These patients will be treated for 3 months, and then we'll look at muscle biopsies before and after treatment. And I mentioned that this will be a start date of approximately December. Before the end of the year, we plan to start this trial. We're working with ABI, and you might be familiar or want to talk about this study in particular. This study has received an incredible amount of attention, both nationally and internationally. We're also going to be doing a follistatin gene therapy trial for Becker muscular dystrophy. This one has also received quite a bit of attention. And we showed a few years ago that we could put the gene in for follistatin. Follistatin blocks the myostatin pathway. And if we inject the gene into the muscle, we get muscle enlargement. This is in the MDX mouse, as you can see here. In the area of the square, the muscle on the right have been injected with follistatin and compared with the atrophied muscles on the left. More importantly, what we did was we went on and asked if they could do it in the mouse, could it do it in the monkey, which is much closer to humans, and we injected the monkey quadriceps at 3 sites that I have shown here on this slide. And what we found is that we got very robust muscle enlargement and increase in muscle, not only an increase in muscle size, as you can see there, but an increase in muscle strength. So on the far right-hand side is follistatin injected quadriceps with one type of promoter, as we call it. The middle one is one that's not quite as powerful, but we still get good gene expression and an enlargement of the muscle and increase in strength compared to control muscle. And this is a picture taken after 5 months. We've taken this out to 15 months. And dystrophy patients. The reason we've chosen the quadriceps muscle in vector dystrophy is because this is a muscle that is preferentially weak in these patients. And if we can increase the quadriceps muscle strength, then we should be able to make a clinical difference, and that's what we're targeting. Now, those are all the studies that we have ongoing and that we've done, and Jesse's Journey has been involved basically with all of these studies. But one of the things that we want to do as we move forward, I mentioned about we want to move to a vascular delivery trial for Duchenne dystrophy. And we actually have the money available to move to a vascular delivery trial. We have two NIH grants. One where we were able to show that we can do vascular delivery with this NIH grant and with the money we got from Jesse's Journey. And we have a new NIH grant that we just got where we'll be able to do a clinical trial with vascular delivery. But what we don't have is proof of principle in the Duchenne patients as opposed to the limb-girdle patients that we can inject the muscle directly and get good gene expression by circumventing the problems that I mentioned, by circumventing the immune response. So that's pretty much where we are and what our intentions are, and I really want to thank with the support of Jesse's Journey, we've been able to make great progress, and I appreciate everything you've done. Hopefully we can get further support.